So we're here with Dr. Ennis, a medical doctor from Texas. In fact, he has a practice in two cities. One is Desoto and one is Irving. And he's operating a medical emergency facility. Did I describe that right, Dr. Ennis?
That's correct. Actually, we started about 30 years ago, and the name of our firm was Emergency Care Center, and we were one of the first medical facilities that tried to practice emergency medicine outside the hospital. The industry became known as urgent medicine.
Got it. Well, why don't you, because, we probably as patients don't know enough. What's, for instance, the difference between going to a hospital for emergency care versus coming to you? Are you treating patients after the emergency care also, basically, meaning do you have a continuous clientele there? If I come there with an emergency, can I be treated all the way along for my normal illnesses and for my normal medical care as well? And maybe, so tell us a little bit the philosophy of your practice, if you don't mind, and what one can expect there. And maybe even, if you don't mind, telling us what made you becoming a doctor in the first place, and maybe what made you then going into emergency care.
I'd love to. Actually, I started my clinical practice as an emergency physician. And when I was an emergency physician, I recognized that about 95% of the things that I treated in the emergency department could also be treated in an outpatient medical facility that had a few more pieces of equipment than a regular doctor's office. And so while I was a practicing emergency physician, I decided to start an urgent care facility, and at that time we called it the Emergency Care Center. We had three primary objectives. We said three, and we said primary because all three were important. The first primary objective was to practice the same or better quality care as a hospital emergency department. And we made decisions by way of staffing of personnel and equipment that were related to the standard of a hospital emergency department. Not a major trauma center, but rather a community hospital emergency department. The second objective was to be able to do that, to be able to practice medicine in a time frame that was on an average daily basis of 60 minutes or less. It was always our thought that the patient's time was just as important as our time. And most people that had urgent problems wanted to see the doctor, get a diagnosis, and leave and go on about their way.
That's a very refreshing thought. A doctor thinking that the patient's time is as important as his own one. I'm probably trying to make fun here of doctors, which I shouldn't, but it is. We're used to kind of like, well, the doctor is busy type of attitude, and we feel a little like, well, am I chopped liver? And so it's nice to have somebody structuring his business around the other people's busy schedule, or anyway, especially now in this time of age where, for instance, people can't just leave work because, well, they get fired. They're already hanging on to the job, with a string, and they can't just leave. So they need to be being seen fast in order to get back. Otherwise, it all doesn't help much. So that's really nice to know. I'm sorry to interrupt you. What's the third one?
Oh, you amplified everything that was important, and there's no question about that. The third objective, the primary objective, was to do that at a cost savings to the patient, 30 to 50% compared to the hospital. And so with those three primary objectives, we developed a business plan and made judgments of equipment and personnel and what we were going to do next to be able to accomplish those objectives. And to be able to do that, we monitor ourselves with a computer-aided audit process, and we evaluate our performance on a daily basis in accordance with those three objectives.
Okay. Let me ask you about the third objective of being 50% cheaper, kind of, more or less. Does it really matter to the patient? Don't most people have an insurance?
When I first started, it mattered a lot. because a lot of people did not have insurance, and a lot of people paid either with Visa or cash or check. And so from that perspective, it mattered a lot. And our prices could be controlled by the marketplace, which was very good. Now I would agree with you that it doesn't matter as much because the prices are not controlled by the marketplace, but rather on the basis of standards put together by the government and adopted by the insurance companies.
Mm. But still, there's probably lots of people out there who have no insurance. I'm sure you're still seeing that?
Oh, my goodness, yes. We certainly do. About a third of our business is related to workers' comp injuries. About a third of our business is related to administrative examinations that are qualifying examinations for some employer or some particular task. And then about a third of our business is private business that's related to people that walk in that have urgent or even non-urgent problems. Of that third of business, I would say about half of that business is cash business. And so we still see a lot of people that have no insurance.
Mm. All right. And of course, you still, compared to the hospital, probably see them faster, better, with more personal care, I guess.
Absolutely. If somebody stays in our facility longer than an hour, we have some red flags that start, and we take a hard look at why that happened. Now, every case, obviously, if a patient has a problem that needs 2 hours of care, we don't shove them out the door in an hour.
Right.
But most cases that are minor, urgent nonetheless, but minor, can get in and out in less than an hour. Even if somebody falls and slips and needs an x-ray of a wrist or a hand, we can usually do that in less than 60 minutes.
Beautiful. So basically it's the empty time, the waiting time you're cutting down. Whatever the treatment time is what the treatment time is. But, you're not rolling a guy on a bed and there he waits for an hour for the nurse to come and another hour for the second nurse to come. And then finally the doctor walks in, and then 2 hours before the results come back. And that's kind of what's not happening, right?
Absolutely. We have an X-ray facility within each X-ray room within each facility. So if an X-ray is needed, it's very easy to roll the patient on a stretcher or in a wheelchair, or if they can walk right into the X-ray room, take the X-ray, and they're back in the room. So the X-ray room is really adjacent to the trauma rooms, and so instead of a patient needing to go to the basement or the third floor for X-rays, they walk 10 steps, have the X-ray, and then they're back in their room. And
Beautiful.
I'm sorry, sir?
Beautiful. Beautiful. That's good. Let me ask you this question, Doctor. You said you have lots of workman's comp and probably personal injuries like a car accident or whatever it might be. Many patients there have the problem that they're not quite getting the reimbursement from the insurances, or they get, the damages paid, the suffering damages. And are you pretty good in making, putting it in a way that actually the insurance does accept it? Because lots of it has to do with pretty good documentations for the insurance to say, yes, we pay. Because just saying he has pain, he needs this, that's why sometimes chiropractors, I notice, have a hell of a time getting insurance claim processed, because they may cure it or whatever, but they're not documenting it to the satisfaction of insurance. Do you have any special in your practice? Is that part of your expertise?
Yes, it certainly is. Actually, in Texas, we're required to make judgments in accordance with ODG guidelines. And one of the things that we've done is to be able to have our computer look up the ODG guidelines on the fly and transmit them to the physician that has evaluated the case, so that that physician is aware of the ODG guidelines by way of what are the standards of practice for this particular diagnosis. Certainly documentation has always been important in the medical profession. It's more important now because there are many, many, many more people looking at the record. 30 years ago, the person that looked at the record was the doctor and maybe the patient and maybe the employer. Now we have the doctor looking at the record, the patient looking at the record, the employer looking at the record, the adjuster looking at the record, sometimes the state of Texas looking at the record, and sometimes even the auditor of the adjuster or the auditor of the nurse case manager looking at the record. And so having a legible record is critically important for all those people that are involved in the process of taking a patient from an injury back to maximum medical improvement. We have we use an electronic record, particularly for all of our workers' comp cases, to be able to do that. And one of the features that makes us different from other urgent care providers is that once we store the information in our computer as to the adjuster of a particular employer, when we get finished with our documentation and procedure, that information is immediately either faxed or emailed to the adjuster. So it gives the adjuster information that allows us to work together on a case instead of fighting each other on a case.
Right.
That's what we like to do. It's still hard sometimes. It's still, adjusters and doctors don't get along. And
well, that's why the patient needs the doctor on his side, basically.
Absolutely. We've taken a little different approach. Not every adjuster will come in line with us, but we've taken a little different approach than others in that we've said, well, an adjuster's here. They're here to stay. Let's try to communicate with them very well. Let's get them on our side so that we can all work together for this case to be able to get this patient back to work as early as possible.
And reimbursed the way he's supposed to be reimbursed.
That's correct. That's exactly right.
Good. All right. So how long have you been in doing this now? How long have you been in practice?
Actually, our Irving facility has been open for 31 years.
Great. And one, a question I touched on. So once a person comes in, let's just say with an injury, can he choose you to be his primary care physician down the road, or is that not happening or not desired?
Actually, you asked that question, and I didn't get to answer it, or I didn't answer it. I apologize. Certainly, the biggest exposure that we have towards patients are those that present to us as workers' comp visits or administrative examinations. And our hope is that they like us during that interchange, and so our private cases are usually cases that have come back to us because they like what we've done to them at treating them for a workers' comp injury. And so we have lots of cases that we see for diabetes, hypertension, sore throats, pneumonias, obviously influenza, things of that nature. All of which are primary care problems. Obviously.
Right. So if I get hurt, I somehow come across you. I like you. I can be. You can do my primary care physician work, and I could even bring my kids and my wife if even though they didn't have an accident. Yes or no?
Absolutely, you surely can, and we certainly encourage that. One of the nice things about the kind of practice that we have, as opposed to my work in the hospital emergency department, is being able to follow up cases. Having an injury or a problem that we've treated, we don't have to pass it on to somebody else. We can actually look at our work and make sure that things go well, and if they don't go well, then intercede quickly. And so being able to follow up a case to a conclusion has been a tremendous benefit by way of fun and pleasure for all of us as physicians.
Right. There's nothing more than also, eating the cake, baking a cake and eating it too, basically get the result out of it, kind of see your finished work. Well, Dr. Ennis, it was a pleasure talking to you, very informative. I'm going to talk to you more about how you actually help some of those people, if that's okay.
Thank you very much, Helmut. I enjoyed the conversation.
You're welcome.